For iron deficiency and anemia associated with iron deficiency, iron supplements are available. So these are iron agents, iron molecules. They can be oral, that means in the form of pills, or they can be injectable. So these are mostly, almost entirely intravenous iron. So they are injected. There are also agents that are not iron. These are called erythropoiesis stimulating agents, or ESAs. These are mostly injectable. In the future, we may also have oral agents for anemia management that are not iron, are similar to ESAs. So therefore, the agents, the treatments or pharmacotherapy is divided into irons and ESA or ESA like agents. So there are several guidelines, including European best practice guidelines in nephrology, as well as kidney disease or KDOQI, Kidney Disease Outcome Quality Initiative. And there is also something known as KDIGO, Kidney Disease Improvement Global Outcome, which is secondary to KDIGO and best European practice. They all are relatively consistent that anemia in persons with CKD should be managed. They define anemia as hemoglobin below 12 or for women or below 13 for men. And they also suggest that anemia is reversible. It should be monitored and should be treated. And the goal is to increase hemoglobin within the normal range. Or according to some, hemoglobin should be between 10 to 11 or 10 to 11.5 or 9.5 to 11. So as you can see that there is a good amount of overlap here, since we don't treat the number strictly, we treat the patients. And also in terms of iron indices, iron saturation and ferritin in persons with CKD are suggested to be above certain ranges and threshold levels. So these are the goals or the suggestions of the guidelines. So the guidelines recommend that iron deficiency be identified and managed while ESA is offered or even prior to ESA. So adults with CKD not on iron or ESA therapy, trial of IV iron, or 1 to 3 months of trial of oral iron is recommended by KDIGO guidelines. An increase in hemoglobin concentration without starting ESA treatment is desired, as stated here, without even starting ESA treatment. That means the primacy goes with the iron. And transferrin saturation below 30% or ferritin below 500 nanograms per ml should be treated. Same guidelines also suggest that if a person with CKD is under ESA therapy, that means erythropoiesis stimulating agents, trial of iron in the form of IV iron or 1 to 3 months of oral iron should be the goal. And with the same targets, I mean, transferrin saturation should not remain below 30%, and ferritin should not remain below 500 nanograms per ml.